Welcome back to the deep dive. Today, we've got a really specific mission lined up for you. We're going to take a serious, really in-depth look at a topic using some source material you shared.
That's right. It's chapter 47 from a clinical text.
Exactly. And the
Yeah.
subject is, well, it's complex and it's critical, unintentional weight loss.
Yeah, and when you hear weight loss, most people probably think about um, dieting, trying to lose weight on purpose.
Right, for health or fitness.
Precisely. But this chapter, it really hammers home that when weight loss happens without trying unintentionally, it's a completely different ballgame. It's
What?
often a really important signal, a red flag, you could say.
A red flag from the body.
Exactly.
Yeah.
Indicating there might be deeper underlying health issues going on that, frankly, need attention, need investigation. It's not just about vanity or the number on the scale. The chapter frames it as a signpost pointing towards potential illness. So our goal here for this deep dive, using just this chapter as our guide, is to go way beyond just skimming the surface. We're planning to meticulously unpack really every concept that's presented in chapter 47.
Every single one.
Everyone. We'll cover the exact definition they use for unintentional weight loss, or UWL.
Yeah.
The physiology behind weight regulation, how that changes as we get older.
Which is fascinating in itself.
It really is.
Yeah.
Then there's just the huge range of potential causes listed in the chapter, and then how clinicians actually assess it, the whole process, and the first steps in management. All based strictly on what's in this chapter. We're aiming for that, that deep understanding.
Like the elite professionals,
Yeah.
trying to get to that level of detail.
That's the idea.
So this isn't a quick overview. We're going deep, escalating the details. So, based only on what this chapter tells us, let's unpack this. Why is unintentional weight loss, UWL, something we need to pay such close, serious attention to? What makes it so significant clinically?
Well, the chapter gets right into the definition. It says involuntary or unintentional weight loss, UWL, is often insidious.
Insidious, meaning sneaky, slow.
Yeah, exactly. It can creep up gradually. Maybe you don't notice it at first, or you don't realize how significant it is until it's pretty far along. It's usually not like, boom, you lost 20 pounds overnight. It's often a slower burn.
Okay.
But the source gives us a clear benchmark, a clinical line in the sand, you might say, for when this gradual loss becomes clinically important.
Okay. What's the threshold?
It's defined as losing 10 pounds. It's about 4.5 kilos, or, and this is key, losing more than 5% of your starting body weight.
5%. So that's relative then.
Exactly. It depends on your initial weight. And this loss needs to happen over a specific time frame. It's
Yeah.
somewhere between 6 and 12 months.
Got it. 6 to 12 months. So quick math. If you weigh 150 pounds, 5% is 7.5 pounds.
Right. Over 6, 12 months, that hits the mark?
And if you're, say, 250 pounds, 5% is 12.5 pounds.
Correct. So either hitting that 10-pound absolute loss or crossing the 5% relative threshold within that 6 to 12-month window. That's what the chapter flags as needing clinical attention.
And the chapter gives some stats on how common this actually is.
It does, and they're pretty eye-opening. It says UWL shows up in up to 8% of all adult outpatients.
8%. That's a
Man.
lot of people just going to their regular doctor visits.
It is, but then I listen to the number jumps like way up for a specific group. It's seen in up to 27% of frail individuals age 65 or older.
Wow, 27%. Nearly 1 in 3 frail older adults.
Exactly. That statistic alone really underlines why this is such a big deal, especially in, geriatric care.
Okay, now this part. This is where the chapter points out something really interesting, something that highlights just how complex this condition is.
Yeah, this is a key finding they mention.
It says that even after doctors do all the tests, the history, the exam, labs, imaging, the whole workup, in up to 1/4 of patients,
45%.
they find no identifiable cause for the weight loss.
Think about that. A clear, significant clinical sign. You throw the diagnostic playbook at it, and 1 out of 4 times, nothing definitive. The mystery remains.
That's kind of staggering, actually. It really speaks to the limits of, well, our current understanding, doesn't it? Something the chapter implicitly acknowledges.
Absolutely. And then the source adds another layer of complexity to actually assessing it.
Oh, what's that?
It contrasts that finding with another surprising point. Apparently, up to half of the people who say they've lost weight actually have no documented proof of it.
So they feel like they've lost weight, But the scale doesn't back it up over time.
Precisely. Their subjective feeling doesn't match objective measurements. So the chapter implies you can't just take someone's word for it. You need confirmation, which adds this sort of initial hurdle in the whole process.
Right, confirming the loss itself is step one.
Exactly. And the source is very, very clear about the serious consequences if UWL is confirmed, especially in older folks. It lists some really deleterious effects.
Like?
Increased risk of falls and fractures, probably from muscle weakness, maybe poor bone density.
Okay, makes sense.
Pressure ulcers are more likely, less padding, maybe impaired circulation if they're less mobile,
Right.
impaired immune function, so they're more vulnerable to infections,
Mm.
and, really importantly, decreased functional status, meaning they lose the ability to do everyday things needed for independence, quality of life.
That's huge.
It is.
Yeah.
But maybe the most critical finding the chapter emphasizes, the one that should really grab your attention, is the strong link between significant weight loss and increased mortality.
It actually increases the risk of dying.
Significantly. The chapter doesn't pull any punches.
Uh-huh.
It says it's a serious prognostic indicator. It even gives a range.
Yeah.
And it's chilling. Increased mortality from 9% up to as high as 38%.
38%.
Within a relatively short time, usually 1 to 2.5 years. And here's the crucial qualifier the source adds.
Okay.
In the absence of clinical awareness and attention.
So if it's ignored.
That's the implication. That little parenthetical is incredibly important. It suggests that recognizing UWL, investigating it, addressing it, it isn't just about finding a problem. It might actually change that grim outlook.
So clinical attention matters. It can make a difference.
That's what the chapter strongly suggests. It really underscores why understanding the information in this chapter is so vital.
Okay, so pulling these first pieces together. UWL, defined by those specific thresholds over 6-12 months, isn't just a symptom. It's a major clinical sign, especially worrying in the elderly.
Yeah.
It's directly linked to bad outcomes, falls, infections, losing independence, and even higher mortality rates if it's not addressed.
Okay.
And it's tricky. The cause can be hard to find, and sometimes even confirming the loss needs careful checking. The chapter really sets it up as a complex, urgent puzzle right from the start.
Okay, let's unpack this a bit further then. Moving from what it is and why it matters to the sort of the biological backdrop the source gives us. This chapter talks about how weight regulation and body composition naturally change with age, right?
Yeah.
Which helps distinguish normal aging from, well, abnormal loss.
Yes, exactly. The source lays out a typical age-related path for total body weight, assuming you're healthy. It generally peaks in the 6th decade, your 50s.
Okay.
Then it tends to stay pretty stable through your 60s and 70s until the 9th decade, your 80s. After that, it usually starts a gradual decline.
So weight holds steady for a couple of decades after peaking.
Total weight, yes. But, and this is a really critical distinction the chapter makes, total body weight is different from lean body mass. Fat-free mass, basically muscle.
Ah, okay. Muscle mass changes differently, drastically differently. The decline in muscle starts much earlier. The source says lean body mass starts decreasing by about 0.3 kilograms a year, starting in your 20s.
The 3rd decade, wow.
Yeah. And that rate of muscle loss picks up speed. It accelerates after age 60 for men and 65 for women. So even if the scale isn't changing much for a while, the body's composition is shifting. Less muscle, more fat. It's often called sarcopenia later on.
Okay, so what's driving that muscle loss so early, according to the chapter?
The source points to key physiological drivers. A big one is the age-related drop in growth hormone secretion.
Growth hormone for building tissue.
Exactly. Muscle, bone, everything.
All right.
As growth hormone falls, so do levels of something called IGFI, insulin-like growth factor type I. Think of IGFI as a messenger for growth hormone. It carries out many of its anabolic or tissue-building effects.
So less growth hormone, less IGFI signal, less muscle maintenance.
Precisely. And then there's the loss of sex steroids. Estrogen decline during menopause in women, and the more gradual drop in testosterone in men. These also contribute significantly to shifting body composition away from muscle. Now, the source notes that in healthy older people, an increase in fat tissue can initially balance out that muscle loss, keeping total weight stable for a while. That explains the pattern.
Ah, okay, so the fat masks the muscle loss on the scale initially.
For a time, yes. But the chapter clarifies that in very old age, like 80s and beyond, both fat mass and muscle mass tend to fall.
And it even mentions changes at the cellular level.
It does. Briefly mentions telomere shortening, those caps on our chromosomes getting shorter, a marker of cell aging, and a general decline in overall body cell mass. Body cell mass is basically the metabolically active part of our cells. These cellular changes sort of underpin the larger tissue loss we see.
Okay, so that's the body composition side, changes in what we're made of, and the lower metabolic need from losing muscle. What about the input side, energy intake?
Right, the chapter highlights a really significant factor here. Our average energy intake goes down quite a bit as we age.
How much are we talking?
The figures in the source are striking. Between age 20 and 80, average daily intake drops by up to 1,200 kilocalories for men
1,200?
and 800 kilocalories for women.
That's huge. That's like a whole meal disappearing over 6 decades for many people.
It's a substantial reduction. And the source connects this logically to feeling less hungry as we age.
Why do we feel less hungry?
Well, the chapter links it back to a couple things we just talked about. Reduced physical activity levels, which are common with aging, and crucially, that loss of lean body mass.
Because muscle burns more calories.
Exactly. Less muscle means a lower resting metabolic rate. Less activity means fewer calories burned through movement. So the body's overall demand for calories decreases.
And that translates to less hunger, less drive to eat.
That's the connection the chapter makes. And beyond those big shifts, it details several other more specific, age-related physiological changes that can make older people more prone to eating less and thus potentially losing weight. These are really important nuances.
Okay, what are they?
Things like declining chemosensory function. That's smell and taste getting duller.
So food just doesn't taste or smell as good.
Right. Or maybe familiar foods taste different, maybe unpleasant. If food isn't appealing, you're naturally going to be less motivated to eat, right? It directly hits appetite and intake.
Yeah, absolutely. What else?
Reduced efficiency of chewing. Could be dental problems, weaker jaw muscles.
So harder to eat certain foods.
Yeah. If chewing is tough or tiring, people might switch to softer foods, which might be less nutritious or calorie dense. Or they just eat less overall to avoid the effort.
Makes sense.
Then there's slowed gastric emptying. The stomach takes longer to empty food into the intestines.
How does that affect appetite?
Well, food sits in the stomach longer, making you feel full or satiated sooner during a meal and for longer afterwards.
So you eat less at the meal and maybe skip snacks or delay the next meal.
Exactly. Both reduce overall daily intake. And finally, the source mentions alterations in the neuroendocrine axis. That's the complex system of hormones regulating appetite.
Hormones like leptin.
Leptin, yes, which signals fullness from fat stores. Also, cholecystokinin, released by the gut after eating to signal satiety. Neuropeptide Y, which normally stimulates appetite. The chapter suggests age-related changes in these signals, or our sensitivity to them, can disrupt the balance, maybe reducing hunger signals or exaggerating fullness signals.
So multiple subtle changes all pushing towards eating less.
That's the picture the chapter paints. It says these things, declining senses, chewing issues, slower emptying, hormone shifts, they all contribute to feeling full earlier, a general drop in appetite, and even less sort of pleasure derived from eating.
Less enjoyment in food itself.
Right. And the force states these factors collectively contribute to what's often called the anorexia of aging. Not necessarily a complete loss of appetite, but a significant blunting of that drive to eat.
And the chapter makes a really key point here. These physiological changes don't happen in a vacuum, right?
Absolutely not. The source explicitly notes that these physiological changes very often occur alongside social and environmental challenges common in older age. Things like social isolation, poverty, and immobility can layer right on top, making undernutrition even worse.
So it's rarely just one thing. It's the body changing, plus maybe being alone or not having enough money for food or not being able to get around easily.
Exactly. The chapter really highlights this multifactorial nature, especially in the elderly. It's a complex interplay.
Okay, let's unpack this next section then, which feels absolutely central. Identifying the actual causes of unintentional weight loss. The source gives a really comprehensive list showing just how many different things could be behind it.
Yes, it's extensive. The chapter helpfully groups most causes into 4 main buckets, which makes it a bit easier to grasp.
What are the categories?
First, malignant neoplasms, that's cancer. Second, chronic inflammatory or infectious diseases. Third, metabolic disorders, things messing with body chemistry. And fourth, psychiatric disorders.
Okay, 4 big groups.
Right. But the chapter is quick to point out that it's often not just one thing. A patient might have more than one cause contributing to their weight loss at the same time.
So it can be multifactorial.
Very often. The force also gives some idea of how common these categories are. It says malignant disease, cancer, is the culprit in about 1/4 of patients.
1 in 4.
Organic diseases, it's a broad term for many non-cancer medical conditions, account for maybe another 1/3. the rest. Usually psychiatric issues, medication side effects, or they fall into that uncertain category we talked about earlier.
The 25% where no cause is found.
Exactly. So let's dive into malignancy or cancer. It's listed prominently, both in the text and the table summary. Table 47 to 1 bet.
What kinds of cancer does it mention?
A wide range.
Yeah.
GI tract cancers, liver, gallbladder, bile duct cancers, blood cancers like leukemia or lymphoma, lung, breast, kidney, bladder, ovarian, prostate. It emphasizes that UWL can be a sign of many different types.
And how often does cancer cause weight loss?
The stats in the source are pretty stark. Up to half of all cancer patients lose some weight. A third lose more than 5%. And this one's alarming. Up to 20% of cancer deaths are caused directly by something called cachexia.
Cachexia, you mentioned that before. It's more than just weight loss.
Much more. The chapter defines it as a syndrome. Weight loss plus severe loss of both muscle and fat, along with anorexia, weakness, fatigue. It's a specific wasting process, not just starvation.
And the source says if weight loss is the first sign of cancer.
Unfortunately, it often means a poor prognosis, suggesting the cancer is already advanced. The source also lists some clues that might raise suspicion for hidden cancer during assessment.
Like what?
Things like a smoking history, especially in men. Specific symptoms pointing to a location, like trouble swallowing. And abnormal lab tests. These are flags for digging deeper.
Okay. Now here's where it gets really interesting, showing the breadth. Beyond cancer, the chapter highlights gastrointestinal disorders as really common non-cancer causes, right?
Absolutely. A major category.
What kind of GI issues are listed?
A whole slew of them, affecting the whole digestive tract. Peptic ulcer disease, inflammatory bowel disease like Crohn's or colitis.
Which cause inflammation, pain.
Exactly. Also, dysmotility syndromes, where the gut muscles don't move food properly. Chronic pancreatitis, inflammation of the pancreas. Celiac disease affecting nutrient absorption. Even severe constipation or atrophic gastritis, thinning of the stomach lining.
And how do these cause weight loss? Is it mainly poor absorption?
It varies. Malabsorption is key for things like celiac or pancreatitis you eat, but you don't absorb the calories and nutrients. But for others like ulcers or IBD, it might be pain or nausea. That just kills your appetite.
Or feeling full or bloated from dysmotility or constipation.
Right. It suppresses the desire to eat. The table also specifically calls out difficulty swallowing dysphagia and general malabsorption as distinct GI issues. So it's problems with intake, digestion, or absorption.
Okay. And then the source mentions something maybe less obvious, oral and dental problems.
Yes. And this is so important, especially in older adults, because it's often overlooked but potentially fixable. The chapter lists very specific issues.
Like halitosis.
Bad breath, poor hygiene overall, xerostomia, dry mouth, often from meds, just being unable to chew where to lay, or maybe weak muscles, teeth not meeting right no occlusion, TMJ problems, jaw pain.
Hemodentulous lacking teeth.
Exactly. Even with dentures, chewing might not be great. And of course, pain from cavities or infections, abscesses.
It sounds simple, but if eating hurts or is difficult...
You're just not going to do it as much, or you'll avoid foods you need. The chapter flags these as crucial, reversible causes.
Okay. What about infections?
The source lists chronic ones mainly. Tuberculosis, fungal diseases, parasites, subacute bacterial endocarditis. That's a slow heart valve infection.
And how do infections cause weight loss? Burning more calories.
That's part of it. Fighting infection raises your metabolic rate. But also just being sick, feeling unwell, fatigued, nauseous, no appetite that severely reduces intake. The table also specifically lists HIV/AIDS, well known for causing wasting.
Got it. Then there are endocrine and metabolic disorders mentioned.
Right. Hyperthyroidism is the classic one listed. Too much thyroid hormone.
And that speeds up metabolism.
Exactly. The source explains it increases your basal metabolic rate, so you burn way more calories just resting. It also mentions a specific type in the elderly called apathetic hyperthyroidism.
Apathetic, meaning they don't have the usual hyper symptoms.
Right. Maybe no restlessness or rapid heartbeat. It might just show up as weight loss, making it easy to miss.
Interesting. What else in this category? Diabetes?
Diabetes mellitus is listed. The source notes that if it's poorly controlled, you can get glucosuria sugar spilling into the urine.
And that's lost calories.
Yep, about 4 calories per gram of glucose lost. So it can contribute to weight loss, though it's often not the main driver. The source mentions its incidence increases with age.
Any others? The table mentioned pheochromocytoma, adrenal insufficiency?
Yes, less common ones. The text doesn't detail the mechanisms here, but pheochromocytoma involves tumors pumping out adrenaline-like hormones, massively boosting metabolism. Adrenal insufficiency, like Addison's, means lacking vital hormones, causing severe anorexia, nausea, vomiting, leading to weight loss. The source includes them as things to consider.
Okay. Then cardiac disorders, heart problems.
Yeah, things like chronic ischemia, poor blood flow to the heart muscle, and chronic congestive heart failure.
How does heart failure lead to weight loss? Is it also metabolism?
Partly, the heart works harder, using more energy, but perhaps more significantly, the symptoms really impact eating. Fatigue, shortness of breath, nausea, maybe discomfort after eating. These can severely cut appetite and intake, and there's often inflammation involved too.
Similar story for respiratory disorders. It lists emphysema and COPD.
Very similar, yes. The work of breathing itself uses a lot more calories in severe COPD or emphysema. And again, symptoms like breathlessness, fatigue, coughing. They make eating difficult and unpleasant. Reduced intake is a huge factor, plus inflammation plays a role.
What about kidneys? Renal insufficiency.
Yes, uremia, the buildup of waste products when kidneys fail. The source is clear on the mechanism here. Those toxins cause severe nausea, anorexia, sometimes vomiting, directly impacts intake.
And rheumatologic diseases,
Yeah.
like arthritis.
Right, chronic inflammatory conditions like rheumatoid arthritis, lupus. The source says the ongoing inflammation itself increases metabolic demand. Plus, pain, fatigue, and just feeling generally unwell can interfere with eating and maintaining nutritional balance.
Okay, switching gears a bit. Neurologic causes. The chapter lists quite a few.
Yes, this is another major area. Stroke, Parkinson's disease, various neuromuscular disorders like ALS.
How do these lead to weight loss?
The source mentions they can cause visceral and autonomic dysfunction, problems with how internal organs, like the gut, function, or issues with digestion or motility.
And difficulty swallowing, dysphagia, you mentioned that comes up here too.
Very much so. It's highlighted as a common result of these neurologic insults. If swallowing isn't safe or efficient, intake plummets.
The source also talks about functional disability, problems with activities of daily living, ADLs.
Yes, and instrumental activities, IADLs, the more complex tasks like cooking, shopping. The chapter states functional decline is a common cause of undernutrition, especially in the elderly.
So if someone physically can't prepare food or feed themselves,
Their nutrition suffers, regardless of appetite or underlying disease. It's a crucial link. The source emphasizes physical function impacting nutritional status.
visual impairment is mentioned too.
Right. Problems seeing well enough to cook, prepare food, even handle utensils properly. That directly impedes intake. Could be eye disease or a neurological issue like tremor.
And Alzheimer's dementia is specifically flagged?
Yes, the chapter notes that UWL can be one of the earliest signs of Alzheimer's. Cognitive decline affects eating habits, recognizing hunger, preparing food, underscores why cognitive screening is part of the assessment.
Okay, what about psychiatric and behavioral causes?
The source puts a lot of emphasis here, particularly on isolation and depression, calls them significant, prevalent causes.
How do they lead to UWL? Just lack of interest.
Often, yes, apathy, lack of motivation, inability to care for oneself. That extends to nutritional needs, not bothering to cook, losing interest in food.
And the chapter mentions something about depression and inflammation.
Yes, it connects depression to a potential cytokine-mediated inflammatory metabolic cascade, suggesting depression might actually trigger physical inflammatory processes that disrupt metabolism and contribute to weight loss. It's not just behavioral. There could be a biological link.
Fascinating. Mind-body connection.
Absolutely. Bereavement, grief after losing someone, is also listed as a cause. And the source notes an interesting observation. The weight loss from bereavement often seems more pronounced in men.
Any other psychiatric factors?
The table includes anxiety, paranoia, which might make someone afraid to eat food others prepared or even leave the house, alcoholism, which damages the body and replaces nutrients, eating disorders, and even just excessive exercise without enough calories to match.
And social factors get their own mention too, right? Not just isolation.
Correct. Isolation is re-emphasized as a social factor. Lack of companionship can reduce enjoyment and motivation around meals. But then there's poverty.
A huge one.
The source details the harsh reality, people having to choose between food and other essentials like medicine, a devastating barrier. It even suggests screening questions for doctors. Have you run out of food? Or do you buy less than you need due to cost?
Direct questions. Important.
Very. And institutionalization, like living in a nursing home, is listed as an independent risk factor. The chapter cites a concerning statistic. 30 to 50% of nursing home residents might have inadequate intake.
Wow. Systemic issues there.
Potentially, yes.
Yeah.
Finally, medications, a huge category, especially for older adults taking multiple drugs.
How do meds cause weight loss?
The chapter explains they cause side effects: anorexia, nausea, vomiting, GI upset, diarrhea, dry mouth, taste changes. If food tastes bad or makes you feel sick, you eat less.
And it lists examples.
Yeah, the table mentions things like sedatives, antibiotics, NSAIDs, SSRI antidepressants, metformin for diabetes, levodopa for Parkinson's, ACE inhibitors for blood pressure,
Mm-hmm.
plus a general other drugs category.
Mm-hmm.
With many older adults on 5 or more meds, the cumulative impact can be significant.
Okay. So after all that cancer, GI, dental, infections, endocrine, heart, lungs, kidneys, rheum, neuro, psych, social meds,
Yeah.
the table includes one more category.
Yes. Idiopathic,
Where is
meaning the cause is unknown. It's that honest acknowledgement reinforcing the earlier point. Despite this exhaustive list and a thorough workup, in about 25% of cases, the source says the cause remains unexplained.
It really drives some of the complexity.
Absolutely. And what's fascinating looking at this whole list is how interconnected it all is. The source implies it's rarely just one thing. Age changes lower the baseline, social factors add barriers, functional limits impairability, meds cause side effects, all layering on top of potential underlying diseases.
So assessing UWL needs a truly holistic view.
Exactly. You have to look at the whole person, their whole situation, not just isolated symptoms or organs. It's a complex diagnostic puzzle, as this chapter lays out. Okay, so now that we've mapped out that incredibly broad landscape of potential causes, let's unpack the next crucial part described in the source: how clinicians actually go about assessing unintentional weight loss. Given how many possibilities there are, the process needs to be systematic, right?
Yeah, how do you even start to narrow it down?
Well, the chapter starts by identifying 4 main ways UWL can manifest, the clinical presentations doctors look for.
Okay, what are they?
First, anorexia, the actual loss of appetite. Second, sarcopenia, that loss of muscle mass we talked about. Third, cachexia, the severe wasting syndrome involving fat and muscle loss, weakness, anorexia, often linked to chronic illness. And fourth, dehydration, which can happen if fluid intake drops along with food intake.
So those are the physical signs they're looking for.
Right, but the chapter adds a modern wrinkle related to the obesity epidemic.
Oh. How does obesity complicate things?
It notes that if someone starts out overweight or obese, that excess fat tissue can actually mask the sarcopenia, the muscle loss. It can delay recognizing cachexia too.
Ah, because even if they lose muscle, they might still look overweight.
Exactly. If they lose 10 pounds but still have a lot of fat, the underlying muscle wasting might not be obvious just by looking or even by weight alone. This raises an important point implied by the source.
Which is?
How do you effectively spot significant muscle loss or early cachexia if the patient's total weight or BMI still seems high? It suggests you need more than just the scale.
Okay, so assuming you suspect UWL, confirming it is step one, especially if you don't have exact past weights.
Yes, the source acknowledges you might not always have precise data, so it gives examples of indirect confirmation.
Like?
A noticeable change in how clothes fit, getting corroboration from a relative or friends who sees them often, or the patient's own estimate of how much weight they think they've lost, though that's less objective. Ways to get suggestive evidence.
Got it. Then what's the core initial assessment process the chapter describes? It mentioned table 47-2 summarizes this.
Right, it starts, predictably, with a comprehensive history and a thorough physical exam. The history needs to be super detailed, asking about everything: appetite, diet, chewing, swallowing, bowels, specific symptoms like pain or cough, mood, cognition, social situation, function.
Covering all those potential cause categories we discussed.
Exactly. And the physical exam needs to be head to toe, looking for signs of any underlying disease. And crucially, the chapter specifies the exam must include a dental evaluation.
Because those oral issues are common and treatable causes.
Precisely. Can't skip the mouth exam. Another mandatory step is a detailed medication review.
Checking all prescriptions, over-the-counter, supplements.
Everything. Because, as we saw, drug side effects are a huge potential cause, especially with multiple medications. Finding a culprit there is key.
Okay, history. Physical with dental, med review. What about labs?
The chapter lists specific mandatory lab tests for the initial workup: a complete blood count, CBC, looking for anemia or infection;
Right.
a comprehensive metabolic panel, checking kidney function, liver function, glucose, electrolytes, hitting many potential organ system issues;
Makes sense.
thyroid function tests mandatory to check for hyperthyroidism; and ESR and C-reactive protein, CRP.
Those are inflammation markers?
Yes, non-specific markers of inflammation or infection. They can point towards chronic inflammatory diseases, infections, or even malignancy. Ferritin, checking iron stores, is also listed. and HIV testing if the patient is considered at risk. It's a core panel casting a wide net.
What about imaging?
The source recommends 2 initial studies, a chest X-ray and an abdominal ultrasound.
Rationale being
Oh,
lungs and belly organs.
exactly. Chest X-ray for lung cancer, COPD, TB, abdominal ultrasound to look at liver, gallbladder, pancreas, kidneys, organs often implicated in weight loss.
And standard cancer screenings are part of this too.
Yes, the source includes age, sex, and risk factor-specific cancer screenings, like mammograms or colonoscopies, as appropriate. Given cancer is a major cause, integrating these standard screens is vital.
The chapter also mentions specific screenings for elderly patients.
It did, highlighting the need to screen for dementia or cognitive impairment using tools like the Mini Mental State Exam, MMSE, and screening for depression with tools like the Geriatric Depression Scale.
Because dementia and depression are such common drivers of UWL in this group.
Correct. And then there are specialized nutritional assessment tools for the elderly.
Like questionnaires.
Yes, things like the Mini Nutritional Assessment, MNA, the Nutrition Screening Initiative, NSI, the Simplified Nutritional Assessment Questionnaire, SNAQ. These help quantify malnutrition risk. The chapter also mentions simply observing the patient eat, watching for physical difficulties or behaviors affecting intake.
Getting a clearer picture of the actual eating process.
Exactly. And finally, assessing activities of daily living, ADLs, and instrumental activities of living, IADLs.
Checking their functional ability again.
Yes, formally evaluating their ability to perform basic self-care and more complex tasks like cooking and shopping. This directly assesses that link between function and the ability to get and prepare food, which the source flagged as a key issue, especially in frail elders. Helps figure out if the problem is access and ability, not just appetite or disease.
Okay, that's a really thorough initial workup. Now here's that really interesting point you mentioned earlier about interpreting the results.
All right, this is a crucial perspective from the source. It essentially says that if you do all of this, the comprehensive history and physical, the mandatory labs, the recommended imaging and cancer screenings, and everything comes back normal or unremarkable.
Then
Then the chapter states, major organic and malignant diseases are unlikely.
unlikely. That's significant guidance.
It really is. It suggests that this thorough initial screen is pretty good at catching the big, scary stuff. If it's all negative, the odds of a mere underlying disease drop considerably. It provides some reassurance and helps decide what to do next.
So what does the source advise after this initial assessment, especially if it's negative? Just keep testing randomly.
No, quite the opposite. It advises targeted testing, not undirected fishing expeditions,
Targeted based on.
based on any subtle clues from the initial workup, or if new symptoms develop. The rationale given is that the prognosis for weight loss, where the cause remains undetermined, that 25% group is generally favorable.
Ah, okay. So if the big sweep is clear and the cause is truly unknown, the outlook isn't necessarily dire.
According to this source, generally not. So you don't need to subject the patient to endless, potentially invasive or expensive tests trying to find some zebra diagnosis.
Yeah.
Do the thorough initial investigation first. If that's clear, you can be more measured and targeted in any further steps, but it all hinges on having done that comprehensive initial workup diligently.
Okay, so we've defined UWL, looked at the aging physiology, explored that vast list of causes, and walked through the assessment process. What does Chapter 47 tell us about actually managing unintentional weight loss? What are the first steps?
The source is really clear on the number one priority. Identify and treat the underlying cause or causes found during that assessment process.
Makes sense. Treat the root problem.
Exactly. It reiterates that if you find and successfully treat a metabolic issue, an infection, depression, a GI disorder, whatever it is, that alone might be enough to gradually restore the patient's weight and improve their function. That's goal number one.
And related to that, what about medications if they were identified as a problem?
Right, the source directly addresses this. If the assessment suggested a particular medication was causing nausea or anorexia leading to weight loss, then the advice is to consider withdrawing it or switching to an alternative, if that's clinically feasible and safe.
A direct intervention based on the assessment.
Yes. Can sometimes be a relatively simple fix for drug-induced weight loss.
What about for those patients where no cause was found? The unexplained UWL group.
For them, the source mentions the role of oral nutritional supplements, high-energy drinks, for example.
Do they help?
The chapter suggests they can sometimes help reverse the weight loss in this group. And it offers a really practical tip on how to use them effectively.
Oh, yeah. What's the tip?
Consume them between meals, not with meals.
Why between meals?
The implied rationale is that drinking a dense supplement with your meal might make you feel full too quickly and eat less actual food. Taking it between meals adds calories to your day without necessarily suppressing your appetite for your regular meals. Helps boost total overall intake.
Smart. Simple, but smart. Does the chapter mention other specific treatments? Drugs, maybe?
It briefly touches on agents that are under investigation. Things like orexigenic agents, appetite stimulants,
Yeah.
anabolic agents, muscle builders, and anti-cytokine agents, drugs targeting those inflammatory molecules involved in cachexia.
So, areas of research, but maybe not standard practice yet based on this text.
That seems to be the implication they're mentioned as under investigation. However, it does discuss one specific medication in a bit more detail. Mirtazapine.
Mirtazapine, that's an antidepressant.
It is. The chapter states that in selected patients, and it emphasizes selected, using mirtazapine led to significant increases in body weight, specifically body fat mass, and also increased leptin levels, that appetite-regulating hormone.
So, a potential option, but only for certain people.
That's how the source presents it. Not a universal fix, but something observed in specific cases.
Okay. Anything else on management?
Yes, one more really crucial element highlighted by the source. Exercise.
Exercise. Even if someone is losing weight and weak.
Especially then, if they're able to participate. The chapter states that patients with wasting conditions, including sarcopenia and cachexia, who can follow an appropriate exercise program, actually gain muscle protein mass that gets stronger and their endurance improves.
So, it directly fights the muscle loss.
Yes. And critically, the source connects this back to function. It says these improvements mean patients may be more capable of performing their activities of daily living, ADLs.
Ah, so it helps them stay independent, addressing that functional decline we talked about.
Exactly. Exercise is presented as a key way to combat the muscle wasting and functional consequences of UWL detailed throughout the chapter.
Okay, let's try and unpack all of that. We have covered a tremendous amount of ground, all drawn directly from chapter 47. Started with the definition, the thresholds, the prevalence, especially how common it is in frail, older adults, and that puzzling fact that sometimes the cause just isn't found.
Then we dove into the physiology, the normal changes with aging, that early muscle loss, the hormonal shifts, the big drop in energy intake, and all those subtle changes to senses, digestion, appetite signals contributing to the anorexia of aging, often layered with social factors.
And that incredible list of potential causes. Felt like we touched on almost every system in the body: cancer, GI issues from top to bottom, dental problems, infections, endocrine disorders, heart, lung, kidney conditions, rheumatologic diseases, a whole range of neurological issues affecting swallowing or function, major psychiatric contributors like depression and isolation, stark social factors like poverty, and the huge impact of medications.
Yeah, the breadth is really something. Then we walk through the assessment, identifying the key signs like sarcopenia and cachexia, the challenge of obesity masking things, confirming the loss, the methodical history, physical including dental, med review, the core labs and imaging, integrating cancer and cognitive depression screens using those specialized nutritional and functional tools.
And that really key insight from the source about interpreting negative findings, that a clear initial workup makes major disease less likely, guiding towards more targeted testing rather than just fishing.
Right. And finally, the management principles. Treat the underlying cause first and foremost. Adjust meds if needed. Use supplements strategically between meals for unexplained cases. Acknowledge the ongoing research into specific agents like orexigenics. Note the specific findings on mirtazapine in selected patients, and emphasize the vital role of exercise for rebuilding muscle and function.
We've really seen through the detailed lens of this chapter how UWL is this critical signal. It's not simple. It demands careful, systematic investigation, looking at the whole picture: physical, mental, functional, social, all intertwined.
Exactly. The chapter provides that framework.
Our aim was to go deep, to really absorb the information in this source, pushing towards that expert-level understanding. We've pulled out the definitions, the mechanisms, the causes, the assessment steps, the management principles, all directly from Chapter 47.
Connecting the dots as presented in the text.
So what does all this mean for you, listening? It means recognizing that unintentional weight loss, especially if it meets those clinical thresholds, isn't something to brush off. It warrants a thorough investigation, guided by the kind of comprehensive factors laid out in this chapter. It highlights the complexity, especially with aging.
Yeah, And, reflecting on this deep dive, maybe it raises a final question. Considering the sheer number and diversity of causes listed right here in this chapter, covering almost everything imaginable, and the fact, stated clearly by the source, that sometimes, even after this extensive investigation, no cause is found.
Hmm.
What does that complexity and the existence of that unexplained category tell us about the limits of our current medical knowledge? Even with incredibly detailed resources like this chapter guiding us, it seems the human body, health, and the factors influencing weight still hold some mysteries that remain just beyond our full understanding.
That's a really thought-provoking point to end on. The depth of knowledge is vast, but there are still frontiers. Thank you for joining us for this deep dive into unintentional weight loss, using your source material, Chapter 47, as our map. We hope this detailed exploration has given you a much deeper appreciation of this complex and important topic.